All right, welcome everybody to the next edition of our Teledyne Health educational webinars. Today we have with us Dr. Anna Wanahita. We will get going in just a minute. I've got just a few more people kind of dribbling in here, so we'll give them just a minute. We're pleased to have Dr. Anna Wanahita with us today. Dr. Wanahita is CEO of Regional Brain Institute in Tulsa, Oklahoma. She's a stroke and vascular neurologist. She's been directing stroke programs for over 15 years now and has worked to lead a 7-hospital organization to certified stroke center, has worked with many other health systems to get them certified for both stroke center and primary stroke center. RBI has become kind of a force to be reckoned with in Oklahoma and the surrounding states. And we're looking forward to hearing what she has to say. Dr. Wanahita, you want to take it from there?
Okay, Andy, can you hear me?
We can hear you fine.
Okay, thanks everyone to spend your lunchtime here with us today. And today we're going to talk about the topic that I love, which is stroke and telestroke and also teleneurology. And I would like to emphasize about why is this important service is beneficial for rural hospital. And
hey, Dr. Wanahita, you're muted.
oh,
there you go.
Now, can you hear me?
Yeah.
So RBI, what is RBI? RBI is a physician-owned physician group. We're multidisciplinary. We are focused on stroke and neurology service, and we are basically focusing. We started in Oklahoma until Teledyne and us find each other, and then we're growing to Nebraska, Iowa, and bordering state. Those who need neurology service, including Arkansas, Kentucky, and Indiana too. And we actually cover inpatient, outpatient, service line, and we are consist of 60 plus multidisciplinary provider, but again, focus on neurology. We have 15 neurologists, 5 general neurology, and also 10 of our neurologists had either fellowship or board certified or both, and with subspecialty in covering vascular neurology, clinical neurophysiology, epilepsy, sleep medicine, neurocritical care, child neurology, endovascular surgical neuroradiology, and multiple sclerosis. We have anywhere between 1 to 5 for each of this subspecialty, which is I'm so proud of. And we assemble a deep branch of neurologists, and we will talk and why it's important for this area. So let's get to work. ER, right? Place home away from home. It's in the Roger County Rural Hospital, Friday, 8:10 p.m. when everyone just finished nibbling their dinner. EMS brought 62 years old, right-handed male. He was talking to his neighbor when 8:10 p.m. he suddenly lost his ability to speak, and he had right facial droop, which is recognizable from far away, and he cannot move his right arm and leg. And EMS brought him to stretcher. Symptom persists on arrival. Blood pressure reported by EMS 200/135, heart rate 90, irregular, respiratory rate 16. He maintained his airway and his afebrile. On quick description by EMS, history got from his wife. He had hypertension, he had hyperlipidemia, but otherwise very healthy, hardworking guy, never smoke, never drink, and no history of drug abuse, no known drug allergy. And his NIH stroke scale, on a quick NIH stroke scale, was 16. So just like any stroke, that, like the most important question that each health provider need to ask is, when was the last time seen normal? And on this case, it's less than 24 hours. When you had stroke less than 24 hours, you want to call code stroke. So everyone is aware there is an emergency in the ED. And patient was brought to CAT scan suite, which is how it's supposed to do also, that because there is a two type of stroke. When you had an acute stroke, remember that picture in there, stroke, think fast, act fast. No matter how difficult it is, every minute count. So when you get the CAT scan, all you need is a CAT scan without the dye, CAT scan without the contrast. And there is two possibilities. Either the CAT scan can look like this, where you have a bleeding in the brain, or it can look normal. And I still have patient that was sent out from ER, whether it's in a metro or rural area, because CAT scan was normal. And they said, no, you don't have a stroke. Well, this is how acute stroke supposed to look like when you had an acute stroke. If you already see the changes, either they are bleeding or you had the wrong timeline, supposed to be normal. Next. So what is actually a stroke? Stroke is like a blanket diagnosis. There are two major types of stroke. When your blood vessel blew up, then it becomes hemorrhagic stroke. The blood leakage to the surrounding area. But 90% of stroke is actually there is a cut off of a blood flow to a certain area of the brain. And again, that's a blanket diagnosis, even though you call ischemic stroke, which is 90% of all stroke. There's a lot of cause that can leading into a blockage of the blood flow to the certain area of the brain. But let's talk about what most important right now. When the code stroke was called, remember, think fast, act fast. Stroke is an emergency. A lot of people still think there is nothing can be done when you had a stroke. And that's a misconception, because actually there is possible treatment that can reverse or limit your disability from stroke. For medication, which is called thrombolytic, you have 4.5 hours from the time last seen normal to give thrombolytic. Less than 3 hours is FDA approved, and then 3 to 4.5 hours based on a good data, and it's already applicable to many of the CSC, PSC, or acute stroke ready. You have 4.5 hours from last known normal. And I want this to be a takeaway of this talk because it's very important. You will have a friend, a family, or even yourself that might have stroke symptom. Remember the magic word. 4.5 hours for medication and 24 hours for possible thrombectomy. Next. And how do we educate ourselves, our family, our friend? What is sign symptom of stroke? The data show that many patients know that, when you had heart attack, obviously when you had trauma, because it's painful, but this is the way that we want to educate patient or family when you had sign symptom of stroke. Abbreviation, B FAST. B is for balance, which is that was added because there is so many posterior circulation stroke that was missing. When you suddenly see someone walk like they are drunk, or you feel like you didn't touch any alcohol for the last 10 years, but then you feel drunk, or you feel like you cannot even walk straight. And then if you suddenly see double, or you cannot see the right side of someone's face or the left side of the clock, that might be a sign symptom of stroke. That's E for eyes. F for face. Most people know when you had facial droop, most likely you had a stroke. Same thing with arm or speech. Remember, there's two components of speech, to talk and to understand. So sometimes when suddenly you talk to someone and they cannot get, and it's not because of the accent, but they had trouble understanding, then it might be sign symptom of stroke. And what's T for? For time, because you need to call 911, not to trying to see if they get better in 5 minutes, in 10 minutes. Call 911. Every minute count to save the brain. brain tissue is not reversible. It's not like your skin wound that will heal. Brain tissue is not reversible. And stroke is #1 cause of disability. So rapid and coordination evaluation, think fast, act fast is important. And imaging for acute ischemic stroke. CAT scan without contrast. That's first thing first when you arrive in the ED. And then CTA, head and neck. And since this is focused on the rural area hospital, can all this done in the rural area? And the answer is yes. Most hospital, even in the rural area, had 40 slices or 64 or above CAT scan. And yes, you can look at the blood vessel. How long it takes? About 3 minutes. And there is a next one that CT perfusion does to see how much tissue in the brain that's already damaged. And the green area is how much tissue that at risk for damage. So #1, you look at the CAT scan, whether it's bleeding stroke or non-bleeding stroke. The second is there any large vessel that got cut off? And you see the technology in here is if you had it in here, let's say in a rural area, like 200 miles away from here, the physician that on call can look at it in their iPhone or in their watch. Oh, yes, there is a cut off there on the left side. Look, there is many area to save. This all can be done within 5 minutes or less. Next. So this is just to recap. I can talk about acute stroke for the next 1 hour, but we have a lot of area to cover. #1, the public need to know what is the sign symptom of stroke and what to do. Mean not waiting. Call 911 when you have acute stroke symptom. And what is acute stroke symptom? Be fast. Balance eye, face, arm, speech, and then call 911. Now, in the ED, it's our responsibility to act fast, right? Evaluate the patient, but also we need to make sure that the patient get proper evaluation. Are they a candidate for thrombolytic or not? Are they a candidate for thrombectomy or not? And target stroke. This is a national target that the door to needle to IVTPA need to be less than 16 minutes in 85% of cases, 45 minutes in less than 75%, and less than 30 minutes in 50% of cases. And this is from the door, not the time that patient finally evaluated, to actually getting the treatment. That stroke patient is getting the thrombolytic. And everybody just finally able to take a breath. And at 11:40 p.m., again, it's Friday, there is like a EMS brought the patient, 23 years old, very nice female, and the parents is with her. She has known history of epilepsy. She ate something wrong and ended up with diarrhea for 2 days. She's on Keppra 1,000 milligrams twice a day. And the parents told us that, she had 3 generalized tonic-clonic seizure, started at 11:30 a.m. They wait and make sure that she's, she's okay. 2 p.m. she had another one. And finally, she had the third one. Each one of them only stopped after 1 or 2 minutes without any medication. Patient is still sleepy, slightly weaker on the left, but she has no known history that sometime after seizure, she's weaker on the left side. And it's called thought paralysis, and there is a wound on her tongue, superficial, no longer bleeding, vital signs stable, and she started to waking up as she came, and she answering questions, say no to headache, and she started to follow command. And then, of course, back to back, another EMS is a neuro night here at the Roger County. There is a 57 years old female. She was just seen by her primary care 3 days ago. She had UTI, urinary tract infection, and she was started to feel better on that part, but then today she became like weaker. She started feeling weak yesterday, but today she had trouble walking. And she said that she had blurry vision. She barely able to see what time it is on the clock on the wall. And she's still not able to walk when, ER physician examine. So Again, busy night at the Roger Country, and this is only neurological case. Should these cases transfer to a large hospital, which is 3 hours away, one way? And will it be making a difference if they actually got appropriate evaluation and treatment in the rural hospital and not waiting 3 hours to finally get physician or to evaluate them and started the treatment? So this is my favorite statement. Where you live should not affect health outcome. Sounds easy. We all know it's not. And it's not just you live. Sometimes you go to the lake, you go to the golf course area, which is, like 2 hours away from the metro area. And you never plan to have a stroke. You never have a plan to have any neurological emergency. But will your outcome be different if you're away from metro area? In order to start that discussion, let's talk about the neurology availability, neurology shortage in the United States. We all read the report that there is a shortage on a physician. It's affecting all specialties. It is a real problem that recognized by American Medical Association, primary care shortage, but neurology, unfortunately, is one of the worst that, like there is not enough neurologists. And American Association of Neurology report this is a grave threat to patient care. I'm glad that they finally recognize that. And, like this is reduced access to care, worsen patient outcome, increase complication, and also from the neurology standpoint itself, they got burnout because there is too many patients that they need to see, they need to serve. They're not happy because you don't spend enough time. They're not happy because you don't see them as soon as they need to. And so what about our population in US here? Everyone's get older, baby boomer get older. There is an increasing age of Americans that age 65 or more. And we know age is the biggest predictor on why they need neurologists. And I was surprised myself when I do some reading for this talk that over the last 10 years, not 1 year, there is only growing 598 of neurologists across United States over the last 10 years. And AAN showing that by 2025, the demand of neurologists will exceed the supply by 19%. This is a problem. And also the recent data, 2024, showing it's clearly showing, finally someone put it in the paper, there is a disparity on access to neurologists for rural compared to the micropolitan, compared to metropolitan area. In the urban area, it's not so good either. There is only 27% of patients who already got diagnosis of neurological condition get access to neurologists. And in the rural area, there's only 21% of patients who already had diagnosis. This is not including patients that they know they had symptoms but not officially diagnosis. Only 21% of patients with neurological condition in the rural area has access to neurologists. And even though they have access, doesn't mean that the neurologists have time to really spend the time that they need or have frequency of the follow-up that they need. And that's just talk about general neurology, just like talk about internal medicine. A lot of internists capable on maintain all the subspecialty of internal medicine. But we know when you have complex renal case, you need a nephrologist. When you have complex cardiac care, you need cardiology consultation. Same thing with neurology. We are such in a shortage for general neurology. Sometimes people forget. A lot of these neurology cases, they need advice, consultation to subspecialty of neurology. And there is a lot multiple specialty in neurology, just like internal medicine. There is headache, vascular neurology, neurocritical care, neurointerventional neurology, neuro-oncology, epilepsy, neurophysiology, dementia, movement disorder, including Parkinson, multiple sclerosis, neuromuscular, sleep medicine, pain medicine. Just by the audience itself in here, you will have a friend or family with at least one of those conditions, if it's not more. So, okay, neurology is a shortage. Why is it a problem if all of them is not distributed well? Again, in that recent data, it's showing that, we're already a shortage, and most of them is actually living in the East Coast or West Coast, not the area that we serve as Teledyne and RBI. I mean, almost like 70-80%, they live in there, the neurologists. And now, how about the US population itself? How many actually live in a rural area? According to US population, 19 to 25% of US population lives in a rural area. And that's overall US. If you actually count on, like just the Midwest, including Oklahoma, Nebraska, Iowa, Arkansas, which is our area where we live right now, actually 35 to 41% of people, of population, live in rural area. And that doesn't count that if you spend on the weekend on the lake too, that will be more, right? And then, what about the rural hospital challenge itself? We know there's a lot of challenge, and this 5 bullet point doesn't cover all of those, but they need to increase bed occupancy just to stay open. We know there's many challenges that rural hospital operating in red because they cannot keep the patient in their hospital. And many of these neurological conditions are time sensitive. We know about stroke, but also status epilepticus. There is also like myasthenia gravis exacerbation, for example. There is a big difference when they have to drive 3 hours away or even more and finally get evaluation. And ED physician and hospital, especially in the rural area, they're resilient. They actually had a really good experience treating multiple conditions, including neurology. But they can use advice from time to time from specialists. Or, what's the latest? It's hard to keep up with everything in medicine. What's the latest? And the number of cases on each county might not justify hiring either full-time or even part-time specialists. You don't know when you need it. So from that standpoint, it seems like telemedicine, including in this topic, teleneurology is the solution. So I'm taking that last statement. It seems like telemedicine or teleneurology is the solution. Is that the answer? Is it going to be that easy? What are telestroke and what are teleneurology? What is teleneurology? And most important is, when you actually, okay, I need teleneurology, I'm going to Google it. There is a lot of teleneurology surveys, right? What does actually your hospital need? What is actually your ED, your patient need from this telestroke or teleneurology service? There are many, and a lot of people associate this with I call drive-through service. I mean, like when you have teleneurology, that means when there is a patient with acute stroke, we can call the EC button and the doctor can decide whether they need TPA or not. And that is a lot of public misconception that teleneurology is equivalent to the patient need TPA or not, or need thrombolytic or not. And then is this teleneurology is sponsored by like a big hospital that just using this as a net to actually increase volume of their hospital? Is this for what patient need, or actually what like the hospital need? So again, is something that for example, on these cases, the 3 cases that we talk about, sure, acute stroke, very obvious. Epilepsy need to be stopped, need to be stabilized. But beyond the acute care, beyond that drive-through service, what else do they need? Is these 3 patients need to be transferred out after thrombolytic? Is the nurse or the hospitalist feeling confidence on keeping the patient? And if it is, what do we do? Case 2, same thing. After the seizure stop, what do we do? And where the patient follow up. We're going to address this on the next slide here. Next. So let's talk about comprehensive neurological care with teleneurology, because in the RBI and Teledyne service, we're not one-dimensional. We had experience and it never worked when you look at the patient care from just one dimension. And it's a lot more complex than this, but try to simplify it by, there is 4 components on this teleneurology. One is acute care, second is inpatient service, the next is outpatient service, and then the service line management. And on that, also there is additional service that can be applied to either one, EEG, either regular or continuous, tele-EMG or NCV, and stroke medical directorship, because we also like to build the program. Acute stroke, this is probably the most obvious and what people think about teleneurology, either for acute stroke or other neurocritical care cases. So this is a busy slide. I don't expect everyone to look at it. This is just to tell you, like, the question will be, what cases need to stop in a rural hospital? And everyone's thinking, stroke, it's a big deal, right? Which one that actually recommended, not just by our local, but by nationwide, to transport to the nearest CSC? There is only like 15% or less cases of stroke that actually need to go directly to CSC. And that's why this is like a non-one-dimensional service, because we need to collaborate, we need to train the EMS and the local community too about what to do when you have stroke or neurological emergency, and where to bring and when to bring patient to rural hospital versus bypassing. Stroke or neuroemergency is not reversible, and there is a need for immediate evaluation instead of just bypassing and go straight for 2-3 hours. Key area of distinction on acute care that we always emphasize: fast response, but also safe. For example, like like a average go live to consult time need to be less than 20 minutes, as soon as possible, not waiting till 20 minutes. And safety, we know, just like our experience in ED or in inpatient, when you have a quiet time, you have quiet time, but then when you had acute MI, it came with the trauma, it came with acute stroke. So same thing with us here, we prepare, we always have 2 physicians, primary and a backup. If one tied up with something, then we have a backup that able to manage this acute case too. Inpatient, okay, seizure stop, stable, what's next? There is a lot of advantage on keeping the patient close to home. Not every family has the luxury of being able to transport every day, 2, 3, or 4. And sometimes accommodation hotel is hard for them. And if you end up like keeping this patient in the hospital, you need to know, how's the stabilization? Is the workup, education, and prevention will be as good as if the patient go to the metro area? Will they have the same workup, whether what's the cause of stroke? This is another my favorite statement. You had a stroke not because you're not lucky. There has to be a cause on why you had a stroke. Not because you're old, not because you're out of luck. You have to have a reason why you had a stroke. You need to have a workup. You have a risk factor. And you do not want patient with stroke or any neurological condition admitted and get out not gaining any education and how to manage the risk factor and what medication do they need. You want the hospitalist to have an advice from neurologists. Look, we need to adjust the dose. We need to add second medication. We need to stop this because that's increased the risk. And that's what the inpatient care is needed, not just the drive-through process, but there is a cause, there is a prevention, and there is an education too. That's a big part of every inpatient hospitalization. And the next question, okay, we know what's the medication. They know they need to control and monitor the blood pressure. They know they need to take insulin. Where do they follow up? There is not so many practicing neurologists that had availability. We talk about the shortage. If there is any practicing neurologist as an outpatient, sometimes they don't take any new patient, even if they do. The waiting list is like, it's not uncommon, somewhere between 3 to 6 months, even for initial. even as a hospitalist, or for a neurologist who see the patient, sometimes you end up getting the test that can be done as an outpatient because you don't know. You don't know when they will see a neurologist after hospitalization. And like for example, MRI of the spine, loop recorder. If you know they will be seen in the next 1 week or two, that might be able to wait. If you don't know who's neurologist and where, and it's not going to be until 3 months. As a physician, we feel bad, if we don't test it at that time. And the same thing with length of stay. If we know they're stable and they will be seen in the next few days. And again, primary care can take care of a lot of this, but there is a lot of neurological cases, they don't feel comfortable. Just the same thing when with the hospitalist. And then outpatient teleneurology is not just for continuity of care after inpatient, also referral for the primary and other specialty. This will decrease the need of the patient of unnecessary admission and readmission because they can be seen in the outpatient. And it's provide continuity of care of local resident. We know sometimes when you transfer the patient to the metro area, the whole system will move, including the primary care, the cardiology, and you have this, again, struggling rural area that want to keep the patient close to home. We want to keep the bed occupancy high and the primary care and specialty that available to be filled. And again, subspecialty care. This will also provide, if the patient had complex epileptic case, uncontrolled with 3 or 4 anti-epileptic, this is the way that you can actually get subspecialty care by epileptologists without having to hire an epileptologist because you don't have volume to justify that. Service line management. This is probably the less familiar and why we think this is like a part of the comprehensive teleneurology care. We know there's an acute care, inpatient, outpatient. And, like this is a comprehensive care to monitor, to actually reporting. And this is where, based on our experience, is actually you have the best result, especially if you want your area, your hospital, your region to grow on this neurology care. What exactly you do on the service line? Well, for example, like, again, how do you know we do a good job? How do you know that, the patient is actually okay with teleneurology? How do you know that they don't have any opportunity to improve? We do gap analysis. We have collaborative strategic planning with the leadership. We do data outcome and monitoring and analysis. We do quality control, opportunity for improvement, workflow analysis across surface of that component. And then we meet periodically with the leadership on that regional area. If the program want to grow and want to prove to the regional area that we have a good standard of care, we help them achieve the stroke certification program. And we also help with the community outreach. And then the next question, why cannot you hire a local person to do that? Well, again, 2 reasons. One, we have experience to do this. And then second is, we know how, like, again, it might not be easy to learn and 1 FTE. This way is the same like a subspecialty. We work with your regional people to how do we improve and optimize the result on what comprehensive teleneurology care that you have for your region. So there is a benefit, integrated system, reporting, and improvement on the patient outcome and satisfaction, enhance the program, and reduce all important stuff that for longevity of your program, length of stay, reduce the complication, readmission, and outpatient appointment wait list. Impact of example. And one of this is one of our service line, rural hospital. As you see, over the years, we increased the volume and decreased the need to transfer to the metro area. Very proud of this result. And people think that this teleneurology is just for the rural area. And back to the shortage of neurologists, actually, it's beneficial also to reduce the neurology burnout, increase the quality of the care, reduce the door to needle in a tertiary hospital too. And this is one of tertiary hospital that we serve along with the service line, that the stroke volume has grown 200% over 5 years and achieved CSC certification. We not just emphasize on the volume. We want to know there's a quality. Quality of care is very important. That's example of one of our site, our Telestroke and Teleneurology card. And there is a lot of, there is a drawers there that has like medication that you need, including thrombolytic. We're able to somehow pull it off. It takes years to be able to get this, but it works. And you see how much is impact door to needle time. Now, question, is fast equal to result? Is fast equal to safe? It's very important. This may be you, this may be your family, this may be your spouse, right? And that's why data is important. It's showing based on that NIH stroke scale, what's the average on the initial versus discharge, that you see that fast is equal outcome. And then hemorrhagic conversion on our team is 2.2%, well below 6% national average, which is also showing that, yes, this acute thrombolytic has a risk. And it has, like sometimes it's not a slam down from the story. It's good to have a specialty care to help you decide, help you talk to the family about the risks and benefit and what's the option are. So this is one of the example of, okay, teleneurology is needed. You want a comprehensive care. What is the process? And this is one of example of, with the Teledyne and RBI, our onboarding process, starting from the service agreement and credentialing, privileging, a lot of work. It takes several months for this onboarding process. Selection of equipment, software, formulary, what's best for your hospital, and meeting with the key stakeholders. And I can tell you, this is a one full room. Stroke and neurological care is not just the top C-suite stakeholder. You need to have a buy-in from radiology, from pharmacy, from nursing, from rehab, PTOTSDs, from everyone. Provide go live playbook, complete training for service side team, and the community need to know too about the service. They need to be ready to, and then conduct trial runs about acute case, acute stroke, acute epilepsy, and the coverage schedule, and how everyone's comfortable and know how to reach us on the coverage schedule. So this is just again one busy slide. Onboarding process. There is a telestroke policy, neurology policy, a dangerous drug policy, acute stroke run, the playbook. We will help the site to make sure that they have the playbook, that the nursing and the physician now get the access of that. And that's just one of the example on the right on the acute stroke workflow inside the playbook. So last slide. And again, we, as a RBI and Teledyne, think that teleneurology service in rural hospital is needed. And we are proud of what we offer, and we offer the comprehensive service, not a drive-through. And this is a several takeaway. One, I can talk about stroke because stroke is my love. Stroke is preventable. The best thing about stroke is preventable. Know your risk factor, work your risk factor. And number two is stroke and many neurological conditions are treatable and manageable in the rural hospital via telemedicine. And then number three, time loss is brain loss. If you have acute neurological condition, don't wait until your spouse coming home. And most important, don't go to sleep because, again, time loss is brain loss. Brain injury is irreversible. And thanks again for letting me talk. And if there is any question, and if you don't want to have a question during this session, and you can always contact Teledyne or me or RBI, and we'll be happy to answer your question.
Thank you, Dr. Wanahita. We'll wait just a minute for questions. I think a couple things I noticed. That slide showing transfers and volume growth, that really tells the tale of success in a small hospital and the ability to whittle down those transfers and start seeing increased volume. It's just an amazing slide to me. And a quick question I have for you, you talked a little bit about having a cart in the CT suite. What's the advantage to having that directly in the CT suite?
Well, again, like we start with the CAT scan without the dye, and then after that, then like evaluation if the patient is candidate for thrombolytic or not.
Yep.
And that's used to be the end of it. Now the next one is the patient candidate for thrombectomy or not? And then like again, time is brain, and it also helped for the nurses. After CAT scan without the dye, if they need thrombolytic, either TPA, TNK, they got started on that. And without moving the patient, then you can go proceed with the blood vessel and CTP. Rather than, again, this patient doesn't walk most of the time.
Sure.
You move to stretcher, back to the room, back again to CT. That will take 20, 30 minutes at least.
Sure, that makes a lot of sense. How would you differentiate, since the service that we're providing to these hospitals is a broad spectrum of acute neurology? How do you differentiate between a patient who's basically showing up scared that they might be having a stroke, but maybe it's something else? What's the process you go through to differentiate stroke, or maybe it's a first-time migraine and they're having some visual disturbance and they don't really understand what's going on, or something else?
Well, that's why we have with the comprehensive care like that.
Mhm.
And if there is like an acute case, if they have a stroke-like symptom and it's less than 24 hours, you want to evaluate immediately. And then there is a neurological condition that not acute, but they need to be hospitalized.
Sure.
And we also have provide daytime consultation for that.
Yep.
And that's another thing that, the benefit of having teleneurology outpatient is also if they don't need to be admission, how soon they can be seen as an outpatient. Because, like having neurological condition based on the one initial evaluation in the ER, either by ED doctor or in combination with teleneurology, then there is a three possible way. One, they need acute treatment, and second is they need inpatient evaluation, but not acute treatment. And number three, they don't need to be admitted if they have a proper timely follow-up for teleneurology.
Yep.
As an outpatient.
Very good. Yeah, I think, there's a lot of telestroke programs out there. I think one of the things that differentiates what you guys are doing with our partnership is we really are committed to trying to keep those patients local if it's safe and if it's appropriate. You see a lot of those neurology programs that are really just to grab patients and bring them back to a tertiary center or an academic center of some kind. And that's definitely not the model that we want to see.
We want what's best for the patient. That's always number one.
Yep.
Patient is always, like the first and the center in our care. And I think start with that, then everything will take care on its own. Like that will benefit. We want to grow the program with you in your region. And that will beneficial for the tertiary center too, because they got the appropriate patient and they can be more focused. Their bed can be preserved for those who are appropriate too.
Yep. Perfect. Well, thank you, Dr. Wanahita. This has been great. Always appreciate hearing from you. This is being recorded, will be posted on the Teledyne website if you weren't able to get the whole thing, or if you talk to a friend or a coworker that says, man, I missed it, I wanted to see that. We will get that up there. So thank you again, Dr. Wanahita. This has been a really great presentation. Love hearing about all the exciting stuff you guys are doing.
Thanks for the opportunity.
Yeah, thank you.